2003. That's where he's been since. And he's held several administrative leadership positions at the Ann Arbor VA, including roles in the OCD and PTSD clinics before taking on his current chief roles. He's currently a co-investigator on a Department of Defense grant project examining combination sertraline and prolonged exposure therapy in returning veterans with PTSD, and on another project exploring non-invasive brain stimulation for PTSD. He's taught extensively at the University of Michigan College of Medicine in Ann Arbor, VA, and has published approximately 40 manuscripts and book chapters. The title of his talk today is Leadership Excellence Through Strategic Partnership. So please welcome Dr. Brian Martis.
Thank you, Dr. Antonelli. Can you all hear me? Okay. Thank you, Dr. Antonelli. I was wondering if you were speaking about me or someone else. So thank you for that kind introduction. So first of all, I want to thank you for being here. Thank you for having me. You've treated me really well so far. Nilu, thank you so much. And so I'm very excited to be here. And what I'm going to share with you today is organized as so. So I'm going to give you just a brief background, which is largely redundant because of Dr. Antonelli's presentation. I'm just going to talk about over the past 15, the transformation and growth of the veteran health system, particularly mental health programs over the past 15 years, and my leadership contribution to that transformation on the ground, so in the ecosystem that I live in, and with specific reference to like clinical programs, research training, community partnerships, and other programs as well. And I'm going to talk about a little bit about opportunities for leadership in the future of health and healthcare, and I mean both generally, but also from a VHA standpoint and a partnership standpoint. And finally, what my vision is, my role, and expected contributions to the VA healthcare system and the partner affiliates. I live in this healthcare system now, so I think that we're very similar, and we could talk more about that. So this is the general organization of my talk. I would like it to be informal. In other words, if you have a question in the middle of my talk, feel free to stop me and ask the question rather than wait till the end. So just a very brief background. Again, I'm not going to belabor the slide, but I wanted to make a few points. I am a psychiatrist. I have a very person-centered and evidence-supported medicine approach to psychiatry. My area of expertise and experience and love is trauma, stress, and anxiety disorders. But I am a general psychiatrist. I love internal medicine, and so I just wanted to give you a sense of who I am as a psychiatrist. I've been involved with a lot of rich training and experience programs, whether they were intra or extramural. The one I am particularly proud of is creating a VA clinical grand rounds, separate from the university grand rounds, but associated with it in different ways to meet the needs of our trainees and our staff. So it synergizes in a way that we all are able to attend the university grand rounds, but we have our own, and we go back and forth, and some of the postdocs use our grand rounds. And I feel proud that I was responsible for creating it, recruiting the right person who was a resident and a fellow, and who then became the assistant residency training director, and who's now the chief of the mental health clinic as well. So, and a little bit about scholarship and research. Primarily, my research has been collaborative. There was a time that I wanted to be a researcher, and at some point I was cured of that notion, or rather, I found that there were better people to do it than I, and the better way for me to go was to follow my passion, but collaborate with them. And I'll show you some of the slides where I've collaborated not just personally, but programmatically So, and most of it is to do with stress and anxiety disorders, that's neuroimaging, intervention studies, and neuromodulation studies. A brief note, so I'm assuming that some of you, but not all of you, are associated with the VA in some way. And so this is for the non-VA folks, because I don't want to bore the VA folks with history. But I do love history. And here's the history, just very briefly. Over the past 15 years, the Veteran Health Administration has been absolutely, in my opinion, and I was supposed to say that, whatever I say is my opinion, not the VA's opinion. I just said it. But in my opinion, they've been the absolute leaders in mental health, mental health care delivery. Where does mental health live in a person's health care? Where does it live in the healthcare system? So there were a couple of very important things that happened in the early 2000s. The new Freedom Commission made a very clear statement saying mental health is an essential component of overall healthcare. It seems very simple to people to us, imagining all of us in mental health, but it is not, and it's very profound to make a statement of that at the national level. That led to a lot of rebuilding efforts, 2003 and 4, and then that led to what's known as the Uniform Mental Health Service Package. And this is the first time that the VA delineated the essential components of mental health to be implemented nationally, to ensure that all veterans have responsive access to person-centered, recovery-based, comprehensive mental health services. It's a significantly big document. It is very comprehensive. It goes through every single domain you can think about. It talks about persons, specialized populations, 24/7 care, settings. It prescribes everything, including a mental health treatment coordinator to coordinate the care. As you know, it can get very fragmented at times if patients are having or receive care in different programs, and the programs might not actually talk to each other like we want them to. And a lot of funding, which means billions of dollars, were actually provided to make this happen. So that's just a background about like who I am and what is the backdrop of what I'm going to show you next, which is what are my leadership contributions to leading transformation, growth, and change in these arenas in the ecosystem that I lived in, which is the VA Ann Arbor healthcare system and the University of Michigan partner affiliate, where I've been there, for 14 years now. And stars to remind me to tell you that even though I say my leadership contributions, and I was I'm a central and key contributor, none of this could, nobody can do this alone. And I have amazing clinicians, amazing section chiefs, amazing collaborators, amazing research collaborators, and all of them did this stuff. So if I say I too many times, Sean, you can taser me. So, but even when I say I, it is actually we. And so just wanted to let you know that. And the second part is, we've tried to include our strategic partnerships with our clinical and research collaborators. And that's the CCMR. We have 3 centers of excellence in Ann Arbor, which is the CCMR HS100, the Healthcare Services Research and Development, which is really our strongest group. And we have the SMITREC and BREC. SMITREC has moved away a little bit in terms of the VA organization, but John McCarthy is my neighbor, and every so often when I'm irritated with something, I will call him up and say, you did this. You wrote this paper, and now we have to do this. And so then we have a meeting, and we figure out how we can clinically implement what he figured out on his computer. So, and you'll see a little bit of that in everything I present. So even when I'm talking about clinical and training and research programs, it has, this is in the fabric of what we do. So also, I know I'm preaching to the choir. You all do this well and in many ways better than we do in many areas. So forgive me if that is the case. So basically, it falls into, the leading change falls into, managing change. It's culture, demands, outcomes. This is a significant growth and reorganization of all operations to support the new priorities and to meet the significant increase in demands. I'll show you some numbers. The numbers don't begin to tell you the whole story because there were so many programmatic requirements, involved that the numbers didn't really, and that was a challenge to make clear to folks supporting, staffing and other initiatives. A lot of recruitment efforts, the major transitions, and I feel it wouldn't be wrong to say that today, after say 6 years of, and that's where I really, even though it's been 15 years, I think 6 years of my partnership with Steve Chermak, who we're partners in crime as chief and associate chief and chief psychiatrist. Till he unfortunately was diagnosed with stage 4 pancreatic cancer with liver metastases about 2 years ago, and which is why you see the acting part. But we did this together, and we did this as a team, and so it involves, so we're considered, we have a pretty good reputation both locally, regionally, and nationally in certain areas. We did all these things, so these are the components, we did all these things. But the first thing we actually had to do is to strengthen our clinical programs. We were not happy with our clinical programs. We didn't think they were as good as what we wanted them to be. And we had to put a lot of effort to strengthen our clinical programs. Because we believe that you have to have a foundation of a strong clinical. First of all, that's our central mission at the VA. But we also believe that if you don't have that, it is very hard to support training and research programs and outreach programs. You do have, it's the backbone, at least if you're in the veterans healthcare system. So here's a couple of slides about growth and reorganization. I want you to just forget the numbers and just look at the trends and see that there was significant growth in, from 2010 in the uniques and the encounters that we saw. I personally recruited 120 staff positions in these 10 years. What I mean by that is I literally put together, I often wrote the postings, the position statements, not for everybody, but I was involved in recruiting each one of these people in different ways. I would be the last person they would interview with, and I would be the first person they would meet with when they joined the service. This is a lot of work. I did that. I prioritized that because one of the most important things in general, but particularly in the VA, is you want to pick the right people. You don't have too many opportunities to do that. So when you do that, you don't leave anything to chance. There are times I have not filled a position despite many candidates because we didn't feel that it was the right fit. Why is that? Because I think you know that, but it's very disruptive when you find somebody just because you need to find somebody and then it doesn't work. It's disruptive for the patients, for the staff, for the programs, and you'd rather have some temporary pain than, again, I know I'm preaching to the choir here. So our strategy, I also, if you can't beat them, you have to join them. So we embraced our HR. We decided to meet with them 3 times a month, actually weekly with the recruitment specialist, and every other week with the personnel specialist, the ERLR specialist. That was recognized by their national audit. This is how we're organized now. We're organized as mostly as what's known as a product line. In English, it's functional units. So, and everybody reports to the section, this clinic chief, section chief, associate chief, and chief. I understand you're a hybrid, which is a hybrid between service and product line. But you are more complex and larger than we are, I believe. So, and then there are, so these are the ways that we are organized, and then we have some initiatives that go across, and then we also reorganized our administrative support and our training and research interfaces. Over the next few slides, I'm going to show you something, some examples of our clinical quality improvement, program evaluation, implementation, and again, some of this is, or much of this is done in partnership. And the partnerships mean we consult them, we do things together with them. Several of them actually have effort in the clinical programs, and some don't, but they still are strong collaborators. So I'll just say there's a plethora of measures and surveys in the VA and leave it at that. More important thing is our philosophy. Our philosophy is we wanted to provide the best care possible from the veterans and families' perspective and from the clinician's perspective. It's like BMW. You bring a seat, you make a person sit in, and then you build a car around them. I like that analogy because that's what we did. We wanted the best possible care. And then we decided that if we do that, the measures will take care of themselves. And we're not going to chase numbers. We're not going to chase measures. If we do poorly on a measure, that's a trigger for us to be curious about what are we doing right and what are we not doing right. And often we find that we're doing something right. It's the way the measure is set up, or it's the way we're capturing it or not capturing it. So most of the times that used to be the case. Sometimes we were really doing a crappy job, and so we couldn't complain. We had to quit complaining and start, find a solution. And so I won't bother you with the rest of them. So I'm sure some of you at least have heard about SAIL. SAIL is a broad, it's kind of a bird's eye view of looking at a center and saying, how are you doing in these domains? And if there's something not right, then it's a trigger to look at it deeper. And I think that's the most, and that's probably it was born of true end methodologies to compare healthcare systems. The VA adapted that and then added mental health in the 2014. And so mental health has these three components, which is population access, continuity of care, and experience of care, which are mostly self-explanatory. This is how we do right now. This is the national average, and this is us. This is strange. We're still trying to understand it. It comes from here, which is a patient care experience, which is a survey. I cannot imagine that our patients thought of us, this is what our patients think of us, and now they're here. So this is, like I said, this is a trigger now. I'm very curious to find out, and it has to do something with, what they think about, or in terms of access, is can I get to see my doctor as fast as I can see my doctor, right? Unfortunately, the surveys are also written in a way that are stacked against us, but this is what, this is a result of many years of hard work. It doesn't just happen overnight. I would say at least 6 years that we've, as a result of 6 years of hard work, we feel we're happy to be here. Most of that comes from our experience. This is what our patients think of us, and this is what, and patients actually, there's a provider survey there as well, including our own providers. And this is a continuity measure, which is what happens when you're diagnosed with depression or you put in an antidepressant, those kinds of things. This is a little harder to understand. It is how you serve the population, and that includes how many people with serious mental illness are you treating in your population, how many with service connection. And you can see it's harder to control, and that's not an excuse. I can see Neelu nodding her head, so there's some validation at least. So that's just a snapshot of how we've grown and how we've organized ourselves and how our metrics look like. We work very hard on productivity, so believe it or not, it's like we don't really have benchmarks of what a physician should do, what a psychologist should do, what a social worker should do, that everybody agrees on. And so, and then within that, right, within each of these, the social workers who do outreach, the social workers who do therapy, the social workers who run programs, they can't be all the same in terms of their benchmarks. So what we did is I appointed a task force, had 5 people from representing the administration, physician, psychologist, social worker. Basically everybody was represented, and they came up with, looked at the data, looked at developed a process, included feedback from section chiefs. We ran this by, we asked for input, and then we incorporated it into service operations. So it is now included in every annual performance where you'll know what you're expected to do and you'll know what you're doing. And you will, if you disagree, we sit down and look at maybe you're doing something that we didn't realize you were doing. And so it's a trigger to, we started this in 2013. Steve, he's a geek and he keeps looking at all kinds of numbers, and he was doing this. We didn't know what he was doing till we actually found out we were ahead of the game and trying to come to what we call individualized targets for people. It's really important because how else are you going to know that you're using your resource wisely? You have all these demands, you have these resources. That's the most important thing you need to know if you want to run the organization, is that how can I meet with these demands with these resources, and are these resources optimized? And this is how you do it. It's not fun, but it has to be done. It can be done in a thoughtful way. And so it really improved our understanding of expectations and to smartly manage resources, improve staff interest, and include. So once we started doing this and sharing it with people, people were suddenly very interested for various reasons. And the acceptance is mixed. And that's always the case when you're transitioning into something new. But it was good. Because they can be challenging. So it's not the what, it's the how. It's the how you do it, right? So we all know what to be done, or we have 2 or 3 different versions of what can be done. But the more important thing for me, at least my perspective, is how you do it. Is how you do it makes the entire difference. So that's just a little example of our productivity. And we use it. We use it in doing, and actually we were site visited recently, and again we were cited as possibly a best practice in that regard in terms of looking at productivity. A little bit about hospital-based care. So this is something I am immensely proud of. This is our inpatient unit. Believe it or not. This is a miracle. It is a miracle, because if you can pull this off in a VA system, I don't mean that in a bad way. It's just that there's a plethora of people that you have to satisfy, including the chief obstruction officer. I call him him or her, the CAO. It's a virtual position. But so what we did is I attend, the first meeting I attended was in 2006. And we have a similar version for the outpatient. It was in reality, it was a confluence of leadership will, just good luck that there's money around. It was just a confluence of a lot of things. But the leadership will is very important because I attended every design meeting. You might also, if you disagree with some of the colors, you might have to blame me. So we attended these meetings. We worked with a large group of people. We came up with a design. We came up with, right down to the colors. And right down to what you see here, this is the pièce de résistance. This is an aquarium in the inpatient hospital, acute inpatient hospital. Can you imagine somebody allowing us to have an aquarium in the acute inpatient mental health care unit? We do. And the other part that you don't see here, this is a state-of-the-art unit. It has safety features hidden in every section. So you will see it has a sensor on all doors. So if you try to hang yourself, the sensor goes off. We've already had 3 people rescued that way. They can put more than 5 pounds of weight. All the bathrooms are touch-free. There are no faucet. There's nothing to hang yourself on. The furniture is nailed down. It's kind of unfortunate, but required. There are no hanging wires or art. The arts are all mural. This is the false sky we have because we're on the 1st floor, and it changes light according to the circadian rhythm. So it's chock full of. I could talk about this all day, but so I'm just going to spare you. So here's some of the metrics on the inpatient unit. This is our restraint use, the blue line, and we compared just ourselves with our VISN, which is a VISN 10, which is 11 VAs. Here's a seclusion rate, which is 0. We don't seclude anybody. And this is our follow-up, 7-day follow-up rate, which, again, you can see that we are higher than the target and the VISN average. We were, again, cited as a best practice in terms of sharing this with the entire VISN because people were not doing so. And to be quite honest, it was not a secret. You find the right person to lead the effort, and then they champion the process and bring everybody together, and that's how that happened. So I'm going to not skip it. Okay, so I'll just talk a little bit about clinical interventions. So we have, for those who are non-VA, or so PDSI is basically Psychopharm Drug Safety Initiative. It's an initiative to improve psychopharmacology practice. And you can see here are the possible areas of overprescribing, clinical management problem, misalignment between, and here are some examples. This came on the, this happened after, so the VA had this huge effort of rolling out evidence-based psychotherapy practices, and they paid a lot of attention to that. And a few folks thought that, why don't we, we need to pay attention to psychopharmacology practice as well. And we all know this, those of us who prescribe, is there are lots of guidelines, but if you actually look at the data on who follows those guidelines, it's so variable. So this is a great process. I was involved in both leading this in our center, but I'm also the co-chair for the VISN committee. I recruited a clinical pharmacy specialist who is just outstanding, and so really all the credit goes to her. This is the phase 3. So phase 1 was the general psychiatry ones. Phase 2 was geriatric psychiatry, and phase 3 is substance use. And so we were happy to look and see that the star means you're, in the national average, or close to the national average. To be quite honest, I don't know how we made this. Sometimes, you don't really know, but, and sometimes you can take credit for it, and sometimes you don't. But this is just an example of one program that we had presence, not just locally, but also in our VISN. And here are the 3 programs I'm just going to show you, or 2 programs where these are new programs, innovative programs, not anymore, but when they happened, and how we did in putting them together. So we recruited a few people, we grew the program. This is a penetration rate. This means like how many people in primary care are actually seeing mental health. The national target is 10%. I think is actually low, but it actually happens to be high in terms of getting everybody to meet that target. And so you see the national target, and the Ann Arbor VA Medical Center is pretty close there. What you see growing here is our second site, which is a large CBOC, which came kind of later into the game, because we just didn't have the resources to do it. Guess what? When you have new programs, you actually need resources to implement them, and those of us from the VA know that 4 out of the 5 new programs that we are asked to implement have no associated resources. And so I think that we're the most creative people in the world, but I'm biased. Here's the same-day utilization rate. Let's see how I'm doing on time. Which basically means that how many people who came that day for primary care was seen on the same day. And the national target is 45%. We're close to there. This just shows that the increase in our telemental health program, and I'm very proud of this because most of our telemental health actually is to the veterans' homes. We do home-based psychotherapy. It is actually a win-win because they don't actually have to drive, and you don't actually need the space. For everything else, you need space, which we often don't have. So here's some of the research studies going on in primary care and telemental health that it's fortuitous, or actually by design, that the director of our primary care mental health is also a clinical investigator, and so you'll see a lot of the studies that happen in primary care happen there. We have a really bright and talented and promising addiction psychiatrist. I will not name her because Dr. Grant, I know you will try to recruit her. So she is basically going to use telehealth to expand treatment access for veterans with opioid use disorder. And I'm quite sure she will be funded, if not in the first round, in the second round. I'm just going to skip the Veterans Outreach and Reach, but I'll talk about the Women's Mental Health. This is I'm very proud of this program. Nobody asked us to do this. It was not mandated. We did it because we thought it was important. We had Dr. Sexton gave her 30% of her time to do this, which is an amazingly outstanding job, not just with the Women's Health Program, but also she's done she's had 11 publications this year. She's going up for associate professor. And we're also partnering with the ambulatory care folks to completely resign the women's health clinic space. And it'll be something close to what you've seen in, not as good as an inpatient unit, but these are the various components of the program. Here's one recent quality initiative that they did. I'm going to move on now to supporting our research programs. So we have vibrant research programs. We have 3 centers of excellence in the university. We've seen growth in collaboration. We have mental health and mental health related collaborators, several career development awards. These are the areas, these are methodologies. It pretty much spans everything. I just wanted to give you an example of a senior investigator who's doing a lot of work in our service, does not have clinical effort, but very closely interacts with us, helps us, we work together very well together. Many of his studies are done with our clinical population. I call him for advice for many things. He's really well funded, but this is one of the examples. The second example is like a mid-career investigator, and this is the person that you saw. This is a psychiatrist and director of the primary care mental health program, but he's also a very successful investigator. I hired him as a resident, and he then joined and got his career development award, and then he became, transitioned to. This is why so I'm showing you this because I feel very proud of this. And then we have several early career, about 5 of them. She's just starting out. This is Becca, who just got a career development award. This is Donovan, who actually is transitioning from his career development award to, he just got a merit award. So this is just examples of our research programs. Here's the funding slide, which just shows that we have 26 million in VA research. We have about 10% of that. And this is not actually, I have to explain that. So this is just the VERA expenditure. The actual number is actually twice as much. This is the VERA return that we get, which is 50% of the actual grant funding. But we have approximately 7 million and 11 million in, so about 18 in collaborative research, which is significant. I've not seen your numbers, so you might be laughing at me internally, but it is important in the ecosystem that we have, right? So these are our publications, and I'm most proud about the smallest one. This is growth in publications by our clinicians who have no research time, who have been paired with our researchers, either organically in a grassroots way or actually in a faculty development way. And so that's what I'm most proud of. We have strong training programs. I've heard a lot this morning about your training programs. They're similar in some of the ways that they're organized. There might be a difference of scale. There might be also some differences in, our interns spend their entire psychiatry interns spend their first year with us, and here's the second year. But they're broadly the same. And our psychology programs actually are VA based, so we get a fair amount of money for that. We also have several staff and faculty professional development and well-being efforts. I'll talk a little bit about that. So I'm involved in every recruitment. There's been a lot of salary adjustments that we have made, or retentions, enrichment and promotional opportunities when salary adjustments are hard. There's other ways to enhance and enrich people's lives. We have professional practice groups for each discipline. I attend each one of them. A physician group, a psychology group, a social work group. And then we also have succession planning in terms of clinic chiefs and section chiefs and retreats. We also have people who are interested in caregiver burnout. They're part of the HSR&D group. A little bit about community partnerships. We have academic military VA community partnerships. One important one is the University of Michigan Depression Center and what's known as MSPAN, which is, I always forget, but it's a military, I'm not going to try, but the N is networks. The gist of it is we have the VA for veterans, and we have the MSPAN for their spouses, families, children, and sometimes veterans in the buddy-to-buddy program and the PAVE program, where we actually synergize. We work very closely together. We do our summits together, mental health summits together. We do our trainings together. There are several research collaborators, National Guard. So that kind of ends my section on or at least in summary, I told you a little bit about myself, about the VA transformation, and my contributions to that on the ground. A wide range of things in terms of the growth, in terms of the quality, in terms of new programs, in terms of research, in terms of educational support and community partnerships. And you'll notice the community partnerships comes up a lot in my talk because I think it's really important. That so it's really a quadripartite mission rather than just a tripartite mission. So what are the opportunities? So if you look at, if you haven't read this article, I encourage you to read it. This is a lot of smart people, a lot of accomplished people, a lot of passionate people who have put together this, and they felt that, we're smart enough, we know enough, we have enough. The most important part of this is our will. Are we willing to make a difference in our health and healthcare system? That was actually the gist of it. But here are the details of it, which are, high health costs, disparities, but most importantly, promising opportunities and knowledge to achieve exist. And they talk about this vision of improving, promoting, protecting, and restoring healthcare and helping each person reach his full potential. I think that we are very good at restoring. We're not very good at, I speak for medical science, I speak for psychiatry, I speak for myself. We're not very good at preventing and promoting. And we really need to do that. And to do that, they've asked, they suggest you focus on healthcare well-being, high-value healthcare, and strong science and technology. And basically, it means empowering people, empowering communities, connecting the care, and paying for value, so value-based care, and also modernize our skills, advance science, X-ray, real-world evidence, and measure what matters most. So it did resonate with me, and guess what? Our secretary of the VA, Dr. Shulkin, kind of came from a different angle, but you can see the overlapping elements here, right? They want to empower veterans, empower communities, connect the communities, modernize the systems, give care where it's needed, and importantly, he included suicide prevention, which is really a standalone priority of his, and I know we're doing a lot of exciting work in that area. So, so what does that mean for us? So it means that we have an exciting opportunity to lead the nation at a time of, this is a time of need, and we have an opportunity to lead, and it rhymes. And I think that VAs with strong partnerships are the best poised to do that. We are the best poised to do that, and we want to create and expand indispensable centers of excellence so that we lead the nation rather than somebody telling us, we're going to just cut your budget and you got to do this, right? And it has to be indispensable because it has to meet the need that we need right now, our patients need, our families need, and the system needs. I'm just lucky to be in the system and interviewing in another one. So, so what do you expect of me, which is what is my vision, goal, etc. And to be quite honest, I mean every single word, but it sounds very cliched to me. And so I'm just going to share with you, I had written to one of my colleagues, a clinician research colleague, and I sent him my slides and I said, can you give me some feedback about, like, does this make sense? Do you know who I am? Do you know my story? Do you know what I'm passionate about? And it was completely unsolicited because I was asking feedback about the slides. And this is what he said. And I said, you know, I looked at it and I said, this is a better slide than the previous one. And it may not capture all of my brilliance, but it does, it was very deeply touching and humbling to me that my colleague wrote this about me, unsolicited. And I think it captures the passion I feel for what I do and why I do it, the passion I feel for creating experiences for patient and staff to achieve excellence, the passion I feel about people and collaborating, and the belief I have in the power of diversity, and I mean that in the broadest sense. You can mean that, you know, traditional and the broadest sense, to basically harness the synergy that we have to make, you know, to lead our healthcare system and the nation. So with that, I'm going to definitely acknowledge our veterans and families, without whom, you know, I would not have as much meaning in my life that I actually do, and both my services and, very importantly, my colleagues, mentors, and friends. This is not mutually exclusive, by the way. And I one request that if you're going to throw tomatoes, because this is California, they have to be certified and organic. Thank you. Absolutely, absolutely.
Thank you very much. I I just would love to hear a little more about the inpatient unit and how you guys actually, you know, made that happen. That was just so cool.
Don't get me started. It's my favorite topic, but
I can imagine. I mean, you should be proud of that.
so let me just say, so what happened is, so the story was, our outpatient units were in the basement, and you know, think about all the psychodynamic interpretations we can go through. And our inpatient unit was, you know, one of those old VA units, and it so happened that there was a considerable pressure that we as leaders put on this center leadership, saying we need to do something about this, particularly the outpatient being in the basement. And then so what happened is there was a confluence, and some of it is by design and some of it was by luck, that we had the right, you know, time, place, you know, all the planets just aligned where there was the leadership will from us, leadership will from the center. Monies was just available. There was just some, you know, skip monies available. There was a space. And we engaged this local architectural firm called C2AE, and we had a series of meetings with them. Everybody was represented. We said, this is what we want, and we need you to make it happen. And so once we did, so you have to ask for what you want, right? And then you have to go through endless iterations of what you'll actually get. This is why it's a miracle, and it's why I'm so proud, because veterans just love it. The only problem is our length of stay is 1 year now, no, nobody wants to leave. Um, yeah, we have to like move the bed out, but no. So it was just you have to be, you have to want it, you have to care, you have to not leave the table. So there's lots of stories. So like, for example, interior design, I don't know what, it's a misnomer in the VA, but they came up with some design, and I said, that's not acceptable. I'm not having green carpets and like black walls. Like, what have you changed? So I said, I need 3 palettes. So they gave us 3 palettes, and then we chose one. We lost some battles, like we couldn't have water in the waterfall on the in the outpatient. But the part I didn't show you the picture of them. I really wanted to is the outpatient part. There's a section that has a place for kids where they can sit, they can color, they can write on the wall, and that's very meaningful because our demographic is changing, right? And that recognizes the increase in younger veterans, veterans with families, women veterans. We're very proud of that. But we did it. We asked for it. We didn't take no for an answer. And obviously, everybody else was great in terms of they helped us make it happen. So I don't know if that answers your question. It's kind of, I guess what I'm sharing with you is that was the most important ingredient, is you have to determine your destiny and not give up, which is, okay, so.
All the way over there, Dr. Muchmore, give me a second, please.
So I'm the Associate Chief of Staff for Education at the VA, and so I'm a little bit hyper interested in trainees, and so I was interested in how you have involved the psychiatry residents from University of Michigan in the programs.
That's a great question. I think like I said, we have about 11 a year. They spent the entire first year in the VA. I really like that because nothing like you get first shot at impressionable minds, and my goal is to make them all stay in the VA. We're over 50% of our students, fellows, visiting trainees are our faculty now. And like I showed you 2 people. One of them was an assistant residency training director, chief of mental health. We organized the grand rounds. I recruited him. I recruited the other clinician and many more. So we try to create experiences for them that are the best experiences for them, that they would want to come back to the VA and work for the VA. We do that. The mechanics of that is to, we have the residency training director and the 2 associates. One associate is actually in the VA. She's a site director, and that's how we are represented in the bigger picture of residency training. And so that involves planning. Whenever something happens that involves moving people around and people start getting worried about that, I am involved and consulted. So the associate will always come to me and say, here's what they're proposing. What do you want? And then I'll get a call from Michael saying, the training director saying, I really want to see this happen. And it all goes back to saying, what do we want here for our, for our residency training program? And how can we make the best experience for them? And then we go back and forth and talk about how do we craft that in a way that's where we're equal partners, because we have the same shared goal. So the easiest part for me is saying we have the same shared goal, right? So then it's only an issue of approach, and then like you may have this approach and I may have this, and the other is you may have some needs and I may have some needs, and we have to figure out how there has to be a give and take sometimes to address those needs. And so sometimes I'll say, okay, we'll manage with this, and then the next time we'll say, well, last time you did that, and so that's really how it is. We involve them in the grand rounds. They present. So the grand rounds are divided by theme. every month has a theme, and every presentation has either a journal club, clinical case conference. So they're all involved in each of those things. They also are paired up with faculty purely by interest, not forcibly, to publish. And they publish, and so a lot of that happens in the consultation liaison service and the inpatient service, where they spend a little bit more time. Several of us are involved in their didactics. We try interprofessional didactics in terms of we teach the psychology students or the interns. We have psychologists come. We don't do it as well as we would like to, but we at least do it, and we have plans to do it better. Does that answer? Okay.
Dr. Granholm.
I'd like to hear more about how you facilitate the participation in research of your clinicians and how you help them write papers with no protected time for research.
That's a fantastic question. So let me start off by saying we struggle with that. I think the first thing is, it's like making the statement, right? We said that we want to do that. It was important to us. We wanted to do that. We wanted to do that because our people said, this is important to me. It will enrich my life. I said it was important to me because that's why I'm there. Otherwise, I could be in any VA or any place, right? Why am I there in a VA that's a strong partner affiliation? And we wanted to do it. There's so many benefits. But the first part was to make the statement and say, this is important. Make a collective statement saying this is important to us. So we have a faculty meeting. We talk about career development, training programs, and research programs. In that meeting, we decided that this was important. So then it's the details. It's how do you make things work. So we use our time, and we first of all look at the volunteers. Right, there are some people who will come forward regardless if they have protected time or not. So you take those and you make examples of them. We had a couple, and we make them present. We give them some time, and then the others see that makes, oh, you can do that. So that then makes others also participate in different ways. We consult, which means we created two different committees. One was the Psychotherapy Resource Panel, and one was kind of a research consultative panel where if you have an idea, you want some money and some time, we can actually do that. If you have a well-written art project, and you have so you either find somebody or we can find you somebody. And so we call them pilot projects. Some of that monies came from the Section Chiefs Fund, which the chief negotiates for the chair. And it's not a lot of money, but it's important stuff because, and we have several examples of successes where people have stepped into that and then stepped out into much more substantive, or people step into that and say, this is good. I'm happy doing this. I'm happy collaborating with Mark. I'll see all his patients for his suicide prevention study. So we do that for trainees, and we do that for, so we created a trainee research fair. So every June, the trainees are supposed to present their data in a research fair that with their faculty supervisors that highlights the good work they've done in the VA. So as soon as they start, we'll say you have to have a research fair, so you better start now because otherwise you won't have data. The faculty, we highlight their achievements when they publish. So that's kind of a broad view. The nuts and bolts are important. We do that by, you have to define the parameters of, you have to get support, and then you have to define the parameters and make, you have to, a lot of it is creativity of, but there are some clear paths. They're not just random.
Okay, well, it's a little bit after 1 o'clock, so unless there are any other burning questions, please say thank you to Dr. Brian Martis.
Thank you.